And a little too squeaky happy.
All right. Good evening to our students who are starting to roll in. I love it. We are so excited as a part of the Road to Residency series to be hosting this webinar tonight called Applying to Residency in Family Medicine. Clearly the best choice that you can make. And we're going to definitely convince you of that. You've got four, I would say, pretty dedicated family docs here, and we are going to spend this hour convincing you more than anything that you are making the right choice, because we are assuming you're already choosing us if you're coming on board here. My name's Cameron Matthews. I am a little tired, but happy to be hosting this entire series as a part of the Tour for Diversity in Medicine. We're a separate nonprofit that works with SNMA and LMSA, all obviously focused on a mission of increasing underrepresented minorities in medicine. And traditionally for the tour, we do a lot of high school and college work, but starting 2 years ago with the pandemic, we thought we needed to do some extra steps for our graduating medical students, because we were converting, if you remember, or maybe don't know, but virtual interviews was just a scary concept that year. And we didn't have a way to support our students. So we created this program, and it has just grown into this beautiful thing. And we're just going to keep doing it every year. That's me. I'm a family doc. I live in Washington, D.C., and I serve as chief health officer with a startup company called City Block Health. We're a totally different type of medicine. The startup world is kind of fun, but it's an example that family docs, we can do everything. We do everything, period. And it's kind of fun. I've been with them about 8 months now. All right. I'm going to give quick introductions, but also allow them each to highlight their own experiences and, most importantly, why they chose family medicine as well. But I've got three beautiful women with me. First of all, I just love that we have these beautiful faces on this screen. This is the best part of these type of workshops. But let me start with Dr. Lee. Dr. Mashala Lee is, of course, a board certified family physician and faculty member. She currently serves as the director of the Harrington Trust at Christiana Care's Institute for Research on Equity and Community Health. Again, just clearly exhibiting that family docs, we can do everything. We also have Dr. Ryan Walker, who is a clinical assistant professor in the Department of Family Medicine at Tufts University School of Medicine, an assistant course director for competency-based apprenticeship in primary care, or CAP. And then we've got Dr. Jamie Hill Daniel, an associate professor in the Department of Family Medicine at Georgetown School of Medicine, also here in DC. She's also the interim program director for the MedStar Health Georgetown Washington Hospital Center Family Medicine Residency Program. Ladies, thank you so much for being here. And I'm just going to open it up in the order that I introduced you. Dr. Lee, how did you choose family medicine? Why? And maybe also, why didn't you choose something else? What steered you here as opposed to somewhere else?
Very loaded question. I enjoy reading my personal statement because it said that I was going to be a pediatrician. But I remember when I went to medical school, being in love, of course, with my youth and adolescent population. But also, oftentimes the parents would say, "Hey, Dr. Lee, can you see me too?" And I'm like, "No, right now this is a pediatric clinic." But I was always amazed with the need for that holistic care. And then once the youth got old enough and graduated, I didn't want them to leave me. Like, I have attachment issues, and like I really wanted to be able to provide the best care for my patients through the whole life course. And also, I fell in love with family medicine when I learned about how it was founded. So family medicine was really founded in the need for advocacy, social justice, and caring for the holistic care of our patients. And so in medical school, I was an advocacy and activism concentrator at Brown. And I really wanted to be able to implement the advocacy in my clinical career. And so family medicine really just seemed like the perfect combination. I also initially thought about being a ID infectious disease doc, but I only loved HIV. And so thankfully, when I was training during medical school, I rotated with a few ID docs. I didn't like the fungi, the different viruses other than HIV and hepatitis C. And thankfully, when I was training, HIV had become more of a chronic illness. And so the docs were spending more time treating the diabetes and the hypertension of the patients that had HIV than they were actually the HIV. And so I was encouraged to really think about family medicine. And I trained in Baltimore because unfortunately, there was a significant need for family docs being able to provide HIV care for their patients. And so I really got the best training to be a holistic doc as well as provide the HIV care to my patients. So that's really how I found family medicine, and I'm so glad that I chose it.
Love it. Dr. Walker.
Hi. We have some
Oops. Oh no, she froze. Oh no.
similarities there, Doctor. Oh, can you hear
There you
me?
go. We got you back.
Okay,
Got you back. There
sorry.
you go. You're good.
I was saying that we have a few similarities. I don't remember exactly when I found out about family medicine, but I know that I came in to med school knowing that I was going to be family medicine. I kind of stuck with it. I'm a big planner. So, but I think for me, one of the biggest reasons was my introduction to health was community organizing, patient education, particularly around reproductive justice and health, and also HIV education. And so I wanted to go into a specialty that was going to allow me to continue to utilize those skills and work in communities and with families and be able to incorporate patient education. And so family medicine was that for me. And also having a master's in public health, like where else, does public health and medicine really integrate? And I felt like family medicine is like, I didn't have to try extra to do it. And I felt like they just got it. And I didn't have to explain. The other aspects of family medicine was like I loved everything in variety, and I can't do the same thing all the time. And I was like, oh, I can switch it up. Like in 5 years, if I had just decided I just wanted to focus on this one aspect of family medicine, I could do that. Or if I wanted to change it in another 5 years, I could do that too. So that was something that really drew me to it. And the holistic aspect was also something really important. So I actually have an area of concentration in integrative medicine. And then I also found obesity medicine, which is another where I'm going to get board certified in as well. But my family medicine program really, encouraged me to do that. So yeah.
There we go. Dr. Hill Daniel, why did you choose family?
Wow. I think a lot of what was already said definitely resonates with me. I am not a planner. I am one of those people that just kind of life happens. And I really felt medical school happened to me. I loved everything, classic story. But when I went to my family medicine rotation, I feel like I really found my people. I really understood what was happening and what was happening in the community and how I could really be of service to my community. And I think that was the best feeling. It's still the best feeling. Like with all the administrative work that I take on as program director, and the teaching and the academics and research, it always comes back to community medicine for me and patient care and how do we serve and how do we just try to make it better. So that is definitely, it's always been a passion. And this career in family medicine, it's the possibilities are limitless, right? You can do so much. You can work in any capacity as a family medicine physician, even in politics. Like, I just feel like this is sort of my second career in academics. I started in community medicine, started at FQHC. That was my first love, passion, and now I'm teaching. And I think probably in a couple more years, I'll be doing something else. And it's wonderful. It's just wonderful to have that opportunity and have that job security. Let me also say that because throughout the pandemic, throughout recessions, throughout government closures, we always got a job. They're always looking for family medicine docs. So I'll just say that too.
I love it. I love it. Yeah, no, similar story here. Actually, similar to Dr. Walker, I came into medical school wanting it. And in fact, I chose a medical school without a family medicine department, knowing I was still going into family medicine. I did it kind of crazy. Yeah. Because I figured I was like, I'll get my family medicine training in residency. I just need to, go somewhere where I feel like I fit. I got into the school. I had met the SNMA chapter, and I was like, "I'm going here. I will get through medical school. I'll get to family medicine." I'm weird like that, but no, family for me was never even a question. I absolutely loved OB. I loved women's health. I loved the OR. loved sports medicine. I didn't like peds that much. That's why I probably don't see kids that much anymore. But like, I loved bits and pieces of everything. And so for me, I always wanted to be everybody's doc. I wanted to be that linchpin, be that first line of, I don't want to say defense because we're so much more than that, right? That first line of prevention. I wanted to help my patients. And most importantly, what it eventually turned into is I wanted to see them well. I don't want to just see my patients when they're sick. And that's where the prevention and primary care was so critical, and family medicine, because I just need to treat the whole family. How can you treat just one person? I don't see it any other way. So that was natural for me. And then I agree, Dr. Hildane. I've done everything. I've been in politics. I'm running the startup. I'm doing all this different stuff. And I'm doing it from a basis of like true knowledge of the medical system and understanding primary care, understanding community medicine, population health. Those are all kind of bigger concepts where I feel like I can address health equity and other issues as well too. Exactly. All right. So in family medicine, we have this concept, and I remember doing this as I was interviewing potential residents for the program I used to be faculty for. We have this concept of full spectrum family medicine, right? Is it something that your programs or just across the board, is that something that students should be emphasizing? Is that something, because all of us have like this, you can see we've all taken a narrow path, but you talk to family medicine departments and everybody's like, well, you need to practice full spectrum medicine. Like there's just this like big concept, but I don't know if it's often reflected in reality. How do you guys respond to that if a student's, is kind of stressed or maybe even nervous about this concept of full spectrum family medicine? Anybody?
I'll go first because I don't like the term because it means so many different things to different programs. And it's like, well, this other program had this, but you don't have that. So are you full spectrum? And so I really encourage my students to ask what the specifics, like what are the numbers, like how many deliveries are you going to get, how many, whatever it is that you're interested in, ask about the numbers, like how many peds are going to be on your patient panel, because some family medicine residents are struggling with their peds, or whatever different population. And so I really focused on that. And those questions definitely should be directed towards the residency program director, because they have to report it. So they know. But yeah, full spectrum, I don't know what that means, depending on where you are.
Yep. Along those lines, I typically ask, so where do you see potentially yourself practicing 5 to 10 years? If someone says, I want to go to a rural area and I want to be the only doc in the area, then yeah, you probably need to know how to practice full spectrum family medicine. And my program may or may not be the best one for you. Largely because we're trying to be as open and as honest with our applicants, because we want to ensure that they're qualified and prepared to train in whatever practice they want to do after residency. And a lot of practices, programs are not emphasizing OB as much as others, largely because family docs across the United States on average are not providing as much OB care. And so that concept of full spectrum has changed and morphed a bit over time.
I agree 100%. I felt like when I came to residency, we were full spectrum, quote unquote, had to graduate with 40 deliveries in your intern year, 10 continuity deliveries, inpatient, outpatient. And I think that's what led me to residency life, because I knew I had that training and I could feel comfortable in that world. But it's definitely not a reality for most docs practicing. You choose outpatient practice. There's programs that will tell you, we're going to train you how to open a practice and be, a solo practitioner. And, that's okay too. I think you have to have, sort of what you want and where you want to be, and think about those things when you think about what kind of program you want to be in and where you want to be. Because it's true. You usually start your career where you went to residency. That's where your contacts are. That's where you start out. So think about all of those life things, not just about, full spectrum, or I know you're going to ask about opposed versus unopposed, all those little things that really, that's not it. That's not it. You want to be well trained, of course. So it's more like looking at programs, like you said, being honest and programs that are genuine in what they're willing to offer and what resources they actually have to offer you. Because academic support, patient number, there's a lot of things that go into being family medicine. It's not just full spectrum, you get to see everything.
So then following off of that, because you guys are highlighting some critical, maybe not criteria, but characteristics of programs. If you're interested in practicing rural, what the academics are like, OB, peds, and everything. For your programs, how do you distinguish yourself? Like what else could our students be looking for, I guess is my question. Go ahead first, Jamie.
Some things that we like to highlight, is that like we are a great mix of community and academic medicine. And so we do some teaching, but we still have the feel of a community medicine hospital. And then our patient demographics are some of the things that we typically highlight.
Perfect.
So I feel like you just took my, I was gonna say, I feel like you just took my answer. That's 100%. I mean, we're academic, I guess, by name, Georgetown and MedStar, but, we're mainly a community-based clinic. And our former hospital, Providence, was community hospital. So we've recently changed to MedStar. So I definitely say, that is one of our strengths, that we're a community-based program.
So at Tufts, and I will say I'm biased because I did go to one of the affiliated residencies, but we have two affiliated residencies. One is Lawrence Family Medicine Residency, and the other is at Cambridge Health Alliance, and they're very different. And so Cambridge Health Alliance has a primary care first model in which they are predominantly like outpatient, and they recognize that, and they're like, if you want to be a hospitalist, this is not the program for you. However, Lawrence is very different, which is where I actually attended. Oh
no, she keeps freezing.
And I think, oh, my internet is bad. Can you hear me?
We got you now.
Okay, I was saying I wasn't thinking about it when I was applying, but Lawrence is actually a 4-year program, and so I do want to bring that to the forefront, that there are other 4-year family medicine programs, and when they say they could do it all, I realize that part of it's because they are 4 years compared to and the way that they're structured, and so they too are very much a community academic place, but they also do these areas of concentration, which I think has become more of a initiative by some programs, but the time in which they're spending on their area of concentration is different because they're 4 years. And so I really try to emphasize the structure of the program more so. But there are so many varieties and the how, what programs are offering or not offering.
Exactly. I know for myself, I chose my program. I went to University of Illinois at Chicago. And one of the things that I absolutely loved about my program was where our continuity clinic was. So who were the patients that I was going to have longitudinal relationships with? And we were one of the few. I don't know if any of your programs do it. As residents, we actually were expected to have continuity patients in 2 different clinics. And one was the university clinic and one was an FQHC. So I actually got to see, I hate to say this, full spectrum, but like the scope of different types of patients, because the university clinic, we saw like, girls wanting like acne medication versus like the FQHC, we were, really managing chronic disease and really doing a lot more kind of community-based medicine. And it was just amazing to have 2 different experiences, but we were expected to have continuity patients in both. And I loved that opportunity. So definitely seeing where the residents are practicing, what the support is there. Like I loved very different faculty at the 2 different clinics. I love having the connections. I had a lot of Black women faculty in my FQHC. I loved that. Really getting an understanding of how the teaching was going on. That was a big deal for me as well too. And our residents were always, when I went back and became faculty there, I actually was faculty of my own program as well too. It was pretty refreshing to know that we put a lot of emphasis on how our residents were learning in both of those environments. It's not just you're there to do the work of the practice, like, no, you're there to learn. And I thought that was a pretty important emphasis.
Yeah, to your point about patient population, I think that's so important to focus on because in just thinking about our two programs, CHA is more diverse lingual from a linguistic standpoint. And so knowing that you're going to be working with interpreters and that type of aspect is important. But also at Lawrence, their programming is you're going to learn how to speak Spanish because 80% of the patient population is Spanish speaking, and how they support you in doing that, they really are putting their money where their mouth is because in other residencies I kind of compare, I was like, well, do you have tutors? And so, but you have to go in knowing that not only are you going to be studying medicine and learning how to be a physician, but you also need to learn Spanish. And is that something you feel like you can balance? So
yeah, perfect. All right, turning to kind of the application process. You know, this can be stressful. This can be and we're gonna hopefully help a lot of students do some mock interviews and take some of the stress off and everything. But what would you say you are typically looking for when you're interviewing a student? How should they present themselves? What should they be emphasizing? I mean, there's clearly a lot there. It's a huge question, but what jumps to the top?
I would say some of the biggest things that I typically ask are, how did you even hear about the program? That's typically one of my first questions, because I want to make sure that the person isn't just applying to any and every school that they see. And I also want to dig into why family medicine. So being able to clearly verbalize when you started your love for family medicine and the areas within family medicine that you're most interested in. I also want them to be able to communicate their interest in community medicine and providing care to patients from diverse backgrounds, even if they're not even if they're not applicants from underrepresented backgrounds. I typically ask that question about their experience caring for patients from diverse backgrounds.
Dr. Walker?
similarly, I think for me, one of the key points is why our program. I want to know what research you did, what your understanding of our program is. And then the other component is residency is hard. And so what are your support systems? Do you know how to ask for help when you need help? And so really kind of getting towards like, knowing your strengths and your weaknesses, or things that you need to work on.
I would say similarly, we actually ask a lot of questions about wellness and their ability to get help and recognize, if they're not well and, experiences around that. And then also for us, it's really the fit with the community and the desire to serve, in a community that, where our clinic is, because I find that when we get applicants who just want to be here because of the Georgetown name, they're often very dissatisfied with working in a community setting. And so I'd rather really just avoid that and get people who are really interested and really understand that 90% of what we're doing is community-based care. So.
Perfect. Are you as an admissions committee, as a group, are you looking for anything in particular in letters of recommendation? Stepping away from the interview, that's always a hard piece. It was a hard piece getting into medical school. It's just as difficult, but are you looking for anything to stick out in their letters? Let's start with you, Dr. Hill Daniel. Let's go backwards.
I was going to say that I often am not usually that impressed by letters, to be honest. As someone that has to write a ton of letters, I feel people will have things that they, put in letters. And if you read enough applications from enough people, you'll hear the same things. And so I'm actually more interested in what the applicant has to say, what they write in their personal statement, what their activities have been, what they're passionate about. So I'm much more interested in hearing about those things than necessarily nice words on,
Love that.
letters.
Love that.
I agree. I find that the letter recommendations, they all start to sound the same. And so I think, I think a specific thing that you can do as an applicant is really highlighting the skills that you want them to highlight, rather than this generic, oh, you're great, they're performing almost like an intern. And it's like, okay, what does that mean? I want specifics. And so I think that's something that you can do to help your letter recommendation recommenders, and like giving them a specific um uh patient case that you all worked on, so that they can paint more of a picture for their reader, as someone is on the other side. But it just seems most of them are very generic.
It's more of what type of letter I'm looking for. So if you're applying for family medicine, I would expect that at least one of your letters is from a primary care doc. So either a family doc, pediatrician, or internal medicine doc. Like, I wouldn't want all of your letters to come from specialists. Like, that would make me wonder, like, are you really, really interested in family medicine? So a good letter is pretty much standard, but a bad letter really sticks out. And so I'm always worried when a letter has, well, this applicant is working to overcome and this challenge, and they've done a decent job, but they still have a good more work to do. And I recommend that they spend a little bit more time practicing their case presentations. Like, whenever a letter writer actually highlights those kind of things, that that's a major red flag, because as my colleagues are stating, most letters are pretty okay and standard, but when someone highlights a negative thing, it can really be bad. And so my recommendation for you is not only ask for letters. I know sometimes you're in a hurry to get letters. And so that's another tip early on when you're going through your rotations. If you know that you've knocked it out the park, or even when you start the family medicine rotation, hopefully you're going to be on your P's and Q's and do a great job. But even inform the letter writers up front, hey, I'm really interested in family medicine, so that they can be taking notes and provide specifics for your letter. But also ask, can you, towards the end, can you write a strong letter of support? You don't just want a recommendation, but you want a strong letter of support. And so that really matters.
Love that. Here's a great question from the audience, actually piggybacking on exactly your point, Dr. Lee, around, what types of letters, from whom are they coming? This attendee asks, if I have activities and research on my application in specific non-family medicine specialties, is that a red flag to you as directors that I'm not set on family medicine? So not just the letter writers, but other activities.
Not at all, because as we mentioned, all of us have interests in so many different areas. And if you're going to go into family medicine, we'd almost expect you to have interests in different areas as well.
There we go. Great answer. Great answer. I know oh, go ahead.
Oh, I was just going to say, to me, it's not really like how many activities, it's really the quality of the activity. If you devoted a lot of time and energy, you were the leader of the club, you made up a club, if you really put your passion to work and it shows through, your CV, then I think that is, what I'm looking for. Not necessarily if it's infectious disease or dermatology. You may have just had a really great opportunity with one of those specialties and you took it and it was interesting. But if you learn something and you have, publications or, something to show from it, then that's great.
Perfect. All right, another question. What advice do you have for applicants whose step 2 score will come out after the ERAS is released? So a nice logistics question. How do we deal with the timing of your step 2 scores?
Perfectly okay. I was late taking step 1. I tell people I was legally blind doing medical school the first 2 years, so I had to go away to take a step 1 prep course, and so I was behind taking step 1, and so that also pushed my test date for step 2 behind. But what I made sure to do was I had to rock out step 1, and then I made sure that when I did my rotations or my application and interviews, I already had step 2 scheduled. So at least I could tell them when it was scheduled, and I knew approximately when I should have my score, and I had my score before the end of December. And so that really matters and helps a lot.
All right. Another good logistics questions. Any preferences on how we format the activities section of ERAS, paragraph or bullet point sentences?
I'm bullets all the way. I know some people have differences on this. What I will say is be concise, describe the outcomes and the things that you learn from those experiences. And if you're doing paragraphs, no more than like 4 sentences. Like honestly, we don't spend as long on the applications as you think we do. And because there's many of them. And so you really just want to be really concise so that we get the gist and we can like move forward.
And definitely pull out what the key points are. So if it's full paragraphs, we actually have someone that like reads those and extracts information for us. And so they might not extract the things that you think are most important or your key activities. So if you can put those in bullet points and even prioritize, what were the things that you think are most important or that you want your reviewers to see first, put that at the top. But I agree, bullets will be so helpful.
All right. It's about making sure it's quick and concise and easy to review. Exactly, not too wordy. Another great logistics questions. Can we send in letters of recommendation after we submit our application?
I think you can.
Yeah. It all gets compiled eventually. I think the one thing I used to advise students about, and it's been a while, so please correct me. You guys are much more active faculty, and I'm not currently, but you want to try to at least prepare your letter writers early enough, do everything possible to get that information in together, because it's when the application is all together and the program is able to review all the information that they're probably more likely to give you an interview. And interviews are on a rolling basis. So the longer it takes for you to get an interview date, you've basically already cut your chances because you've missed a bunch of dates. I mean, that's how I think of it. It's just a probability score almost. So try to really talk with your recommenders. You should be talking now when applications are opening up in the next month or so. You should be having those conversations, really providing resources to your letter writers, drafts, even your personal statement, your CV, your ERAS, anything to make it easier on them so there's no reason for a delay.
And to that point, I'm all about being specific. So when you have an ask, tell them when you want it by, include that. The other thing is don't feel bad about sending a reminder email. Sometimes we get busy, we forget. And the other point to that also is that communicating with the programs, especially if you're really, really interested, let them know, especially because, sometimes, if you didn't have that third letter and their website says third letter, like they're not even looking at your stuff until it's filled. And the most important people is the program coordinator. So it's the program coordinator that you want to email to let them know your updates, because they're making all of it work.
So true.
Email them, but don't bug them. So don't email them.
True.
Exactly. All right. Another logistics one, and then we'll jump on. How does a personal statement stand out to you? We're reviewing a lot of these. We need bullet points. We need short sort of information, but that personal statement does provide a great amount of information. What do you recommend a student do to stand out and to make sure you remember them?
That's a tough one. I would say usually it's someone who tells me a good story I'm gonna remember. And it could be about anything, but it just grabs your attention. And so those are the ones, but it's hard to describe it more than that, I think.
Yeah.
Go ahead.
I hate the ones that start with I first learned that I wanted to be a family doctor when, whatever you do, just don't start it that way.
I was
All right.
also gonna say,
Yeah.
I don't like it when they just list their activities all over again. I was like, I just read your email. Like, you don't have to do that.
Yeah.
I want to emphasize, tell a story and really think about a story that speaks to you, like your authentic self, but also highlights the skills that you have that's gonna make you an amazing doctor. And your interest in family medicine. You really want to be answering the question, why family medicine, right? Yeah, and it doesn't have to be as you could be creative with your essays. I think some people are hesitant about that, but it's gonna make it stand out more. Um,
Yeah, totally.
I'm almost positive that you can even have a unique letter for each program, because I remember actually labeling my personal statements like the different schools that I was applying to. And at the end of my letter, I really highlighted like some specific key features of those programs and why I was choosing and interested in their program as well.
Good. Good.
and to that point, make sure you're reading the websites of each of the residencies because there are supplemental questions for certain residencies. If you didn't answer it, it's an automatic no review.
Yeah, exactly. All right, so then when we're choosing residencies this fall, I'm hoping all of your programs are doing something to connect with residents, because it's really a two-way sort of deal, right? You are interviewing them, but you also need to make sure that as much as they fit you, but they need to also feel that your program fits them. And you may have different activities like virtual open houses. Any recommendations? I haven't been through one of these, about how students can stand out in these virtual events. Like, you know, they're meeting people, but how do we help the students really utilize those opportunities the best way? It's hard.
I think, yeah, I think what Dr. Lee said earlier about another point was about the letters is sort of the same thing. You don't want to do anything that is going to make them remember that you were not favorable to them.
Mhm.
Our virtual Zooms are like happy hours with just the residents. So the faculty are not in those more social things, but the residents will say, you know, that person was arrogant, or they talked about themselves or dominated the conversation, or that's not somebody I think I'd want to work with. And the residents get a say on our rank night. And so if you come off in a way that, you know, it doesn't seem friendly to them, no matter how much you shine to the faculty, it may knock you down.
I also wanted to make a point to say that when you're attending these things, we're not like literally writing down everything you say and keeping note. Most of it really is for your information, but it's when you stick out in a wrong way, or perhaps you're asking a lot of questions that are good questions, not just generic questions you can find on my website, because then that tells me you also didn't research my program. And so asking questions, meaningful questions, can help you to stand out, but also you're there to ask questions. So it might not, but just don't stand out on the wrong way.
Along those lines, you know, do your research, but also when you come, listen. So don't ask a question about something that I just said like 10 minutes ago, and you're asking the same exact thing that I explained. So that tells me that you're not listening as well.
All right, so we are obviously purposefully here to help our students in SNMA and LMSA. There may be other students in the audience, but I particularly want to focus on our underrepresented minority students going into family medicine. Those in your programs and applying to your program, so either made it or trying to get there, are there any particular challenges that you're seeing that they are facing? And is there any advice that you would give our underrepresented minority students in particular in entering this season, this application season, but then also coming into residency as a whole? Because this isn't an easy process, but we know we had a little bit difficulty in medical school, but how does that translate into the residency world?
To me, a diversity of faculty and residents was so super important. After training at a PWI for medical school, I was tired of being the only one in class and always felt like if I said something the wrong answer, that everyone thought that all Black people were not smart or something like that. So I really wanted to train an environment where I could just be myself, have good days, bad days. And so I looked for a program that had diverse faculty as well as diverse residents. I was lucky. My class of 10 residents had 6 Black women.
Oh,
And so when I had a bad day, hopefully my co-resident was having a good day. So they weren't like, oh, all the Black women are just mean and angry. So they were able to get a diverse view of the residents, and as well as my attendings and being able to explain and express what's going on in my life, good and bad, and for them to understand. Bad hair days, understanding, having people to understand like why I really need to go to their hair appointment if I can, or why I can't go to the community services weekend because I have a hair appointment. And they understood those kind of things without me having to explain. So that meant a lot, being somewhere where there was diversity.
any other thoughts?
I would say on the other hand, so I went to PWI for undergrad med school, and despite our patient population being 80% Latinx, there's no Latin faculty, and there's like maybe one like community faculty that was Black, and everyone else is white. But nonetheless, I didn't feel uncomfortable. I didn't feel like I was being looked at any type of way. And I think it was because of the culture of the program. So don't be afraid to ask tough questions and say, like, as a Black or as a Latina or a Latinx, like, how do you support residents, and because obviously, like, it's a big thing. Everybody's talking about they're diverse, but not every program can really support you. And so asking those questions is really important. It was really helpful to have one Black male in my class that was from the South because, we were identifying and able to, have a safe person to talk to. But also having white faculty that checked themselves before I had to say or felt like I had to say something. Like they would go back and be like, oh, like maybe I shouldn't like say that, or like, the faculty also fought for us. Like one of my co-residents, the patient referred to him as like brother or something like that. And he's like, is that okay? And he was just like checking on him, like, is that disrespectful? Because maybe they should refer you to a doctor. And it was like, no, we understand. So I think it's really important to ask those hard questions about the culture of the residency, and also retention. This is something that has come up that I feel like we aren't always talking about a lot, but that I've seen with some of the students that I'm mentoring is some people are being pushed out of residencies, and by no fault of their own, but because the program was not a good fit and they don't know how to support them. But it's an unfortunate situation. And so really asking those questions about what is the process if, someone is struggling academically or struggling mentally. Like I remember just being like, hey, if I don't leave, like I might not come back. And they were like, say less, we got you. And the next day they were like, everything's cleared, you can go. So just really understanding how they're supporting you is so important, despite going to a program that didn't look nothing like me.
I definitely agree with all that was said. I think you just have to ask, like, what kind of support does that program offer for board prep, for step prep, for academic support, for professionalism support, for mental health support, wellness. Those are a lot of things now that have become buzzwords. So people are asking, but really, what are you asking for, and what do you understand? How do you, know yourself to be? Like, what do you need? If you know that test taking, you're going to struggle, then those are the kind of questions you want to ask. Like, what kind of resources are there? That's something that we really had to focus in on our program because, we're blinded interviews, so we don't look at scores. And so a lot of times, we just had to come up with a solution that we are going to be able to support residents no matter, what their scores look like. And that looks like extra, academic support. So you just have to ask, like, in programs who can't answer specifically like what they have and what they're willing to do for you, then that's probably not the ones that you want to be at if you know those are things you're looking for.
Great points. Great points. Yeah, I felt pretty well supported. I had, like I said, the two different kind of split experiences almost in residency, and one was literally where all the Black women were, and one was where all the white males were. And like I actually really got along with everybody. Like the program was supportive, but I was definitely the only Black female in my class. I had another one come in 2 classes after me when I was a senior. I think there was a fear, and almost like like I was, as a resident, trying to convince others to come. Like I remember like interviewing and say, come here. It's not because it's bad and I need you here. It's more, this is a great program. Like you can have a great experience here, even though we may not have that kind of critical mass. It's much better now, like looking at it now, and the faculty is more diverse, but it's hard. There's not that many of us, right? So you can't hinge it on numbers alone. So if you're looking for that, I definitely agree. It will, I mean, obviously we're all looking for support, but if the diversity is a big piece, I think you need to step past that. Why is diversity important? Because we support each other. And so asking those questions, what are you doing for students when perhaps there isn't that direct mentoring relationship that they can have with someone that looks like them? How are we supporting, how are we supporting you? What kind of support are we giving for testing, everything? Completely agree with that. But yeah, very few programs out there where you're gonna like step in, like Dr. Lee, it sounds amazing, but you're gonna like you're not gonna be in a class full of all of them. So you gotta get kind of used to it. And then, to be honest, one thing I do emphasize as well is, as much as that's not necessarily a reality in residency, it's for damn sure not a reality once you get into practice, right? And you need to be able to work with anybody that's walking in that door, sit in a meeting next to you, perhaps your boss, perhaps working for you, so being able to really not just show that level of cultural competency to your patients, but that competency with your colleagues is just as critical. And you learn that in residency. It's stressful and it's exhausting, but you learn it. Great.
I think that's 100%. We're 3% of the doctors. That's it. So once you spread this out by specialty and program, you look around, it's not a lot. I felt like I had a fortunate experience. I worked at a Black hospital. The specialists I called were Black, and I know that is what brought me to DC. I wanted to be in that environment, but that was because I'm from the West Coast and I did not have that environment in undergrad, in medical school. I had to seek it out. And so when I had that opportunity, I loved it. And so we try to like hold on to that, even though now our hospital system is different. We still try to keep that, same value in our department.
Exactly. All right, a couple more questions before we close out. Should we mention that they have interest in fellowships? We talked about, obviously being upfront about what you want to actually go into, but is it helpful or harmful to mention that they want to go to that next step, that they're looking for a fellowship?
I would say no. I mean, it's well known, as Dr. Lee had said before, that we all have a particular interest in something. And so to say like, oh, I really like addiction medicine, that's okay. And I think it's important that you state your interest because, they'll be able to facilitate that learning for you, right? And connect you with different resources. So.
Perfect.
I think it can be in a good thing, especially like what you're saying, Dr. Walker, so that they get exposure to those areas. But it can be a negative thing when someone says, like, for instance, we have a sports medicine fellowship. And like the whole interview, all the person talks about is sports medicine. And then you ask about, okay, can you tell me about women's health and what is your interest? And they kind of draw a blank. So it's like, you do know you have to complete family medicine first in order to do the fellowship. So you need to be able to make the connection and show that you're interested in both as well.
Agreed. Yeah.
I think, yeah, I was just going to say, I think that's 100% right. You want that person to have interest in your program and learning to be a family medicine doctor. You can't put the cart before the horse. So it's good to, share your interest and look for opportunities and see what opportunities are there, and make that known. But, you're interviewing for, your internship, your residency position.
All right. And then it looks like maybe a final question, but students, please drop anything else. We got a couple more minutes. This is an interesting one about, I would say it touches on a couple of points. Any advice about opposed versus unopposed programs? Dr. Hill Daniel, you mentioned that before, that sometimes that's not as big of a deal, but this person is saying sometimes you hear that unopposed programs can be workhorsey, and it's true. You hear that, it's true. But how do you guys characterize the different types of programs, whether it's opposed or unopposed?
I'll go first. I think that's interesting because I felt like in my day, you didn't want an opposed program because you wanted to do everything, because you wanted all of the training, all of the deliveries. You didn't want to share labor and delivery with OB. But I've never been in a 100% unopposed program. There's always been internal medicine, OB, surgery docs. I think that enhances your learning. So I don't know about more work, because right now there's plenty of patients to go around all the time for everybody. So the opposed part doesn't change that. But I think it's a nice environment to have other residents and other specialties around you.
I agree. It's a nice environment to be able to lean upon those other specialties. I knew that I didn't want to do surgical care, like inpatient surgery. I also knew that I didn't like running codes. Like I can do it, but like if I need to put in lines and stuff like that, I can do it. But I wanted some support there just in case. And so, but I was tricked into thinking that I was going to an imposed program where our main hospital where we trained was opposed, where different specialties trained, residents trained. But we also spent time in other hospitals where we were the only residents there at night. And so if that question is very important to you, it's not as easy as unopposed versus opposed, because the different training environments can dictate what that structure is like.
Yeah, I just want to emphasize the questions about structure and like the logistics and how things work. I did go to a completely unopposed program, and I loved it. I didn't feel like I was overworked, but we definitely leaned on our specialists. So, like pediatrics, we worked really closely with our pediatric hospitalists, and they rotated and they were based out of Tufts. And so it's really interesting to get their perspective because they, work in the NICU and they have a little bit more acuity than what we were seeing in a community hospital. But we got to work directly with the OB laborers, but we also have family medicine doctors in our OB service, one that does C-section and one that does not. And so that looks very different, opposed to, I know another residency that I interviewed at, they were opposed, quote unquote, but their whole inpatient service was like their service, and you take care of your patients from your health center. And so it feels unopposed because you have a number of patients that you will see. There is no, need to look for patients or feel like you're gonna miss out in that way.
Exactly. I loved learning from the other services. I mean, I just, for me, I even chose between two programs. One was a smaller community program. I purposefully chose more of a community-based academic program because I had a larger faculty, more people to learn from. And then you think the other departments, that's additional faculty to learn from. So yes, you rotate through different hospitals and the like, but even, being on service, we had our own service. Yeah, there was internal medicine services and all that, but we would work together. You're down in the ED together. You see the surgeons. To me, it's just a broader learning environment when it's an opposed program. So I never actually considered the unopposed, but that's kind of scary, Dr. Lee, that you, that you were in other hospitals and they were there. I didn't even think about that. That could have been an option. It wasn't, thankfully, but that could have. It's a good point. That's a good point. All right. Actually, last question. This is a good one. And being that we're family, this is a perfect way to wrap up. How do we ask about support for family planning, presumably as a resident, without sounding like you're trying to have a child during residency? Is this a red flag?
I don't think you even need to ask about it, only because it should now be an expectation that we want holistic, happy doctors. And so whatever program you go to, if you decide that it's the best timing for your family, that's all that matters, and they must support you.
Well said. Well said.
Yeah, I agree. I don't think you have to ask. I think it's just one of those things that, I mean, we expect, and it's a welcome thing.
Love that. All right. With that, we are going to close out this hour. I really appreciate you ladies. Thank you so much for your insights and helping these students. This is not an easy process. And so these questions were great. You guys need to really be digging into a lot of these different differences between programs, and you're hitting the nail on the head with what you should be looking at. Again, thank you for joining the Road to Residency series. For any fourth year graduating students of SNMA and LMSA, you're going to get your mock interview assignments shortly. If you haven't already gotten them, make sure you reach out to your interviewers and get those scheduled throughout the next month so you can really take advantage of that relationship. And make sure you follow all of us on social media, especially Tour for Diversity of Medicine. It's Tour, the number 4, diversity. And I thank you ladies, Dr. Lee, Dr. Walker, Dr. Hill Daniel. Thank you so much for your time. Have a great night, everybody.